For those of you who don't know, I'm going to start back there. The Lowell Hospital Women's Society is an organization of people in all ages and stages of life, passionate about and committed to raising excellence in women's healthcare and treatment. The Society raises awareness and important funds for a variety of initiatives at the Lowell Hospital for Women. We host these mind and body talks as an inclusive speaker series to engage and stay connected with our community. A big thank you, as always, to Alberta Blue Cross for their continuous support that allow us to run these informative series. Please welcome Trish from Alberta Blue Cross, who's going to do a land acknowledgement for us. Excuse me.
Thank you so much, Rianne, and I'm super excited to be here. And again, I'm Trish. I work with Alberta Blue Cross. We're super happy to be able to support these speaker series. They're so meaningful, and we're so happy to be here. So just acknowledging the land today and every day, we respectfully acknowledge that we are on the traditional lands referred to as Treaty 6 territory. We recognize that the City of Edmonton and us, the people here, are beneficiaries of this peace and friendship treaty. Treaty 6 encompasses the traditional territories of numerous Western Canada First Nations, such as the Cree, the Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. We are taking this important moment here today to acknowledge all the many First Nations, Métis, and Inuit people whose footsteps have marked these lands for centuries.
Thank you, Trish.
Thank you.
Now, before we dive into tonight's session, I'm going to provide a quick overview of the evening and just a couple of housekeeping notes. So tonight, we're honored to have guest speakers, Royal Alexandra Hospital Foundation President and CEO, Sharlene Rutherford, and I've been practicing the Kaverzan Chair in Mature Women's Research, Dr. Colleen Norris. We are hoping that you will come away from this presentation feeling educated about all the ways women's health continues to make strides through focused research and the future of women's health in Canada. This is a safe space for everyone to come and have their questions answered. If you have a question for a speaker, please type it into the chat box and we will read it during the Q&A session following the presentation. You can type it in at any time. We'll be keeping notes and keeping track of the questions. So you can put it into the Q&A, into the chat box anytime, but we will be answering all the questions at the end. The lecture is being recorded. It'll be posted to the Women's Society YouTube channel next week. So you'll be able to come back to it if you want to review anything. Tonight we're using the Zoom webinar, so each of the panelists will appear as they speak. You don't need to worry about your own video being displayed, and we hope you enjoy this viewing experience. We are also using the live transcript function. And if you would like to see the available transcript, please enable this on your personal computer. There will be an email or a survey emailed to you following this lecture, and we'd love your feedback. So everyone who fills one out is entered into a draw to win a $25 gift card, courtesy of Alberta Blue Cross. All right, so those are our housekeeping items. And now I get to introduce our amazing speakers. So first to speak with us tonight is Sharlene Rutherford. So Sharlene is President and CEO of the Royal Alex Hospital Foundation. She's a long-serving member of the RAHF. She also leads the Alberta Women's Health Foundation, which is the AWHF. The AWHF was launched in 2020 by the Royal Alex Hospital Foundation to further expand upon its mission in women's health. Sharlene is a fund development leader specializing in campaign strategy, relationship building, and strategic leadership of cross-functional teams. Sharlene began with the RAHF in 2005 and was tasked with developing and executing the communications, media, and marketing plan for the Lowell Whole Hospital for Women and its capital fundraising campaign. At the time, the $22 million campaign was the most substantial fundraising effort in the foundation's history and included fund development for 3 research chairs and a full multi-million commitment to the Women and Children's Research Health Institute. Sharlene fully transitioned to fund development and by 2010 was leading teams across multiple fundraising efforts, serving the C.K. Huey Heart Center, the Eye Institute of Alberta, and Orthopedic Surgery Center, while strengthening donor engagement to advance research, technology, and innovative programs at the Lowesville Hospital for Women. Sharlene is a connector and community builder whose MO is one of long-term vision and big picture thinking. She has been instrumental in spearheading the birth and launch of the AWHF, a new pan-provincial healthcare charity. The AWHF supports the advancement of care and research in women's health by further connecting the dots, harnessing partnerships and collaborations to break down borders and expand fundraising reach across Alberta. I'm very excited to hear what Sharlene says today. But I'm also going to introduce Dr. Colleen Norris. She is a professor. Dr. Norris is a professor and Associate Dean of Research in the Faculty of Nursing at the University of Alberta. She is the Carverzan Chair in Mature Women's Health Research and an adjunct professor with the Faculty of Medicine and the School of Public Health Science at the U of A. Her PhD is in clinical epidemiology. Dr. Norris, a nurse by training, completed postdoctoral training with a Canadian cardiovascular outcomes research team and tomorrow's outcome researchers in cardiovascular health in health outcomes research, and developed the Alberta Provincial Project for Outcome Assessment in Coronary Heart Disease follow-up program. It's called the Approach Follow-up Program. Her program of research focuses on the sex and gender factors that impact women's heart health. She is the past chair of the Canadian Women's Heart Health Alliance, Health Policy and Service Working Group, whose mandate is to implement policies that advance our understanding of the unique sex and gender factors affecting the outcomes of women's heart health. She is a committee member on the Women's Heart and Brain Health Research Steering Committee. Sorry, I did that wrong. Women's Heart and Brain Health Network Research Steering Committee, and is actively involved in advancing sex and gender-based analysis and reporting in heart and stroke funded research. In 2018, Dr. Norris was designated as the Sex and Gender Champion on the CCA Clinical Guidelines Committee, where she established and published a methodology, that will be used going forward to incorporate sex and gender specific information into CCS clinical practice guidelines. Dr. Norris is a fellow at the American Heart Association, a fellow of the Canadian Academy of Health Science, and the COPI in CIHR GenderNet Plus research project going forward, an international collaborative of researchers from 5 countries evaluating the impact of sex and gender factors on outcomes. Dr. Norris has mentored over 90 students and trainees. She has presented extensively and has over 400 publications, that's amazing, in the areas of sex and gender differences and cardiovascular treatment and outcomes and women's heart health. I'm also very excited to hear the things you have to say, Dr. Norris. So without further ado, please welcome Sharlene Rutherford.
Thank you so much, Rhiannon. I want to start by thanking, of course, the Lowesville Hospital Women's Society for the lecture series and the opportunity to present tonight along the esteemed Dr. Colleen Norris, who's so well known right across Canada for the great work that she does in mature women's heart health and heart health. And I also too want to thank Alberta Blue Cross. The lecture, these things don't just happen, right? It requires great, strong support, and Alberta Blue Cross has been such a strong corporate community supporter. So thank you so very much, Trish. I'm going to share my screen for the presentation. So I can call up the, okay. Here it is. Now you can see the screen, correct? You're seeing my slide deck? Think so, yeah?
Yeah, we are.
Okay, terrific. So I'm going to do this. Now you're just seeing one page, correct?
Perfect. Yeah.
All right, thank you. So tonight, I'm taking the first part of the lecture tonight. And my hope tonight is to convey to you all some of the gaps that exist in women's health generally, and certainly gaps in mature women's health for sure. But really some of the root causes of that. And it's both of which relate back to funding, of course. And I hope to share with you how children's health has managed to make exponential gains as a result of support, and how women's health has really, it just needed the same runway, needs the same runway to be able to capture the same successes. So that's the starting point for me. So I'm going to talk about a couple of different brands here. Women's Health Collective Canada, which is a national brand, and then in women's health, and then the Alberta Women's Health Foundation. So it'll tie together, and it also ties in very closely with the work of the Lois Hole Hospital Women's Society and the community support that the Lois Hole Women's Society generates for the Lois Hole Hospital for Women, because all of these are needed. So that's the starting point. So the starting point is this: women's health is behind. I don't know if that's a news flash for anyone. I think for some it might be, because we hear a lot about different fundraising successes in different areas of disease that take up a lot of headlines, and those are important. But the fact of the matter is that medical research didn't involve women at all until the late 1990s. And up until that point, research was exclusively done on men, and the results from men were extrapolated and made to present for both sexes. So there's that side of it all. And I know that Dr. Norris is going to be able to speak on that very well, because it comprises a lot of her work. And for her and even someone like Dr. Sandy Davidge, who is our executive director of the Women and Children's Health Research Institute, Dr. Davidge talks about how men and women are very different, right down to our cells, right down to the chromosomes, X and Y. And as a result of that, the ways in which we metabolize medicines, the ways in which we respond to disease are very different from one another. And it's really now that we're starting to really understand just how far women are behind because of that lack of knowledge, because we have been missing from a lot of those clinical trials. But closing those gaps in women's health research and knowledge transfer and health outcomes actually begins with closing a big deficit in funding. So I want to talk about a major success story, and I think it's important to talk about this success story because it's a big anniversary year for the Children's Miracle Network, which was established in 1983. So this is their 40th anniversary. And in that time, $8 billion have been raised for children's hospitals across North America, starting, of course, in the United States, where Children's Miracle Network was started and expanded into Canada. $30 million is raised annually for children's hospitals and children's health research. All of these funds are also restricted. So when the Children's Miracle Network distributes these funds to children's hospitals through the Canadian Children's Hospitals Foundations, they are unrestricted dollars. So the children's hospitals are able to use them in whatever capacity of research they wish to, or however they wish to use those dollars. So after 40 years, that's a long runway of success. And that's the result of being able to create corporate partnerships over those years. So the Children's Miracle Network has been just an amazing success story when it comes to creating partnerships with corporations throughout North America. So this is actually a page from their website, and this is the Miracle Million Club. So these are just a few of their brands that are part of this club. And to be part of this club, you raise a minimum of $1 million every year for children's hospitals. So that's a minimum. Many of these brands raise much more than that each year. And it goes beyond corporate Canada and corporate America. It also extends into philanthropic families as well that truly support children's health outcomes and children's health research. And it's very important. So another one, most recent example that I could draw upon, and this is from the headlines, and this is Shopify. The family behind Shopify, the Thistledown Foundation, just recently announced a $26 million investment to the 13 hospitals, children's hospitals across Canada. So I bring this forward and say this is a success. This is tremendous. And my point here is that women's health deserves to be in this space too. And this is not a matter of an either or, it's an and. It's children's health research and women's health and health research. There is enough for everyone. Women's health is important. You know, we're half the population and we've given birth to everyone. So women's health is very much public health. It is community health. Corporate Canada is interested in women's health. And it's a case that makes great sense. And it's also an opportunity for more women to support women's health research initiatives. So the vast majority of people who support children's health charities at the cash registers are women. So we need to help women understand too, in fact, all people understand that women's health and women's health research is also in this space. So enter Women's Health Collective Canada. So Women's Health Collective Canada is in the same space now as the Children's Miracle Network. Before this, there was no brand for women's health operating in this space, and so we've created it. And it was created by 3 women's foundations that support women's hospitals and also support women's health research institutes. So that would be us, the Royal Alex Hospital Foundation. And now what we've done is created the Alberta Women's Health Foundation to be in this space for women's health, alongside BC Women's Health Foundation and the Women's College Hospital Foundation in Toronto. So Toronto, BC, and Alberta, the 3 of us came together, and it's actually the 3 CEOs from these foundations came together and said, we need to exist in the same space as children's health if we are going to approach corporate Canada to give to women's health research, so we can begin to close these gaps that exist. So we're following the Children's Miracle Network model because it works. So we know that corporate social responsibility is noted and measured. Corporations give in multiple ways. There's sponsorships, there's employee giving, and there's customer giving, like cause marketing. So for example, when you go through the self-checkout and you're invited to donate $2, $5, or $10 to a charity, that's a cause marketing or a cause-related marketing. More donations than ever are now happening at the cash register, at point of sale, in different at different locations, whether it's retail, well, mostly retail stores, right? And things like your drugstores and different point of sale locations. And again, as I said, the vast majority of people who support children's charities are women. And so we've created a brand now and an opportunity to support, to give back to women's hospitals and women's health research institutes in the same way that the Children's Miracle Network gives to children's. And so this brand, Women's Health Collective Canada, launched in January of 2021. And I can share that, you know, launching during a pandemic was not what we anticipated, but we did need to push ahead. And I'm glad that we did, because we've started to traverse down that road. Now, look, Children's Health has 40 years of history through the work that they've done through the Children's Miracle Network. We're only just getting started, but already we can see the interest, and we can see through working with these brands that have already joined us in a number of activations and different events. We're you know, about to reach our first $1 million mark. And that's in both sponsorship giving, cause marketing giving, and in media through W Network. So again, why is this important? Because, you know, we needed to have a brand in place that really demonstrated the need across Canada to share why women's health research is important, and certainly research is without borders. So whatever we know that for Women's Health Collective Canada, there's a reason why, you know, it doesn't really matter if the researcher is in Alberta or in Toronto or in BC or in Halifax or in Montreal. The researchers work together. They work together nationally. They work together internationally. I know that Dr. Norris can talk about the cohorts and the papers, certainly in 400 different publications that she's been involved in. I can imagine there's been a lot of researchers who've collaborated on those papers, and I'm sure they're not just in Alberta. So let's take this down to the Alberta Women's Health Foundation side of things, and specifically what we're doing. So one of the things that we wanted to do through the Alberta Women's Health Foundation is better understand the landscape here in Alberta when it comes to women's health research. And so what we did is we took a look at what was happening in BC and what the BC Women's Health Foundation did. And what they did is they hired a researcher to study the research and to study the investment in research in BC. And what they found was that it was about 4%. So we did the same thing. We thought, let's find out what it is for Alberta. So we did the same thing. We hired a researcher to study the research and put together really a report on the investment here in Alberta, what our share is, and it's 3.4%. Now, women's health research across Canada receives only 8% of federal funding. So that was the baseline, is the federal funding and the distributions of federal funding into the provinces. And so our number is 3.4%. Through understanding in looking at a cohort of researchers that studied grants through Canadian Institutes of Health Research, this is interesting. This is separate from us, but this is something else that was learned, is that less than 40% of 14% of male applicants were awarded national grants, compared to only 9.2% of women. And that 70% of the grants submitted to national funding institutes are submitted by men, and only 23% of academic researchers are women. Now, why are those percentages important? Those percentages are important because a lot of the research that happens in women's health research is actually conducted by women's researchers. So that's problematic if women researchers are not being viewed equitably in the share of the funding, right? So that's problematic too. So what is the result of all that historically over time? Well, we know that 80% of people with autoimmune disease are women. 35% more women than men die of stroke. 50 to 75% of adverse drug reactions occur in women. Women are less likely to receive the same diagnostic tests as men, even when they exhibit the same or similar symptoms. And I think Dr. Norris is going to touch upon this specifically in her presentation. And also, in terms of mature women's health, there still remains lack of knowledge generally about the effects of menopause and how symptoms debilitate women in the workplace. And that's symptoms too, in terms of just even having your period, right? So I think that we're in a place where we're recognizing how far we still need to go in really truly understanding women's bodies and women's health and health outcomes and how this impacts us. We do know that sex and gender and race and culture and socioeconomic status certainly have all been shown to play pivotal roles in a person's health and their experience interacting with the healthcare system. And if we're understanding anything, we're also understanding in a big way the Indigenous experience and how we really need to do much better there. It's one of the reasons why our foundation is also supporting the Indigenous Cultural Program partnership at the Lois Hole Hospital for Women. And we actually started by supporting the Indigenous Wellness Clinic at the Royal Alex. So there's work there that's happening that's resulting from this research. So if you've ever had a chance to listen to Dr. Sandy Davidge, the Executive Director for the Women and Children's Health Research Institute, speak, she can read chapter and verse on how women's bodies respond differently than men's, to a number of different illnesses, disease, and medications. So this list here: autoimmune conditions, anxiety, breast cancer, bladder control issues, depression, dementia, osteoporosis, stroke, migraines, thyroid diseases, urinary tract infections. Those impact the population, men and women, but they impact women in greater levels and differently. So this is really consequential when you consider the lack of knowledge and how it applies then to the 2.1 million girls who live in our province, 49% of the population, right? There's a lack of knowledge on how these things are impacting us. So if we take this down to the individual, health is very personal. It's very public, but it's also personal, right? So this little girl on this page is Paisley Polanski. She's the daughter of our video content lead at the hospital foundation, Kyle Polanski. This is his daughter, Paisley, and she's 2 years old. She's just adorable. But through the passage of time, if you can think of when women's health research, women were first included in medical research in the late 1990s or in the 90s. And if it takes 17 to 20 years or even longer for research to go from the lab or the bench to the bedside or be put into practice, if it takes that long, let's think about how little Paisley now too. What about when she's 20? So let's think about how quick that's actually going to go, right? That's going to go pretty quickly. What if the investment in women's health research, and we're starting to hear about some very positive things with cervical cancer, right? With the HPV vaccine and testing efficacy of that. That's the result of research. But what if we could eradicate cervical cancer completely? What if there was 100% cure for breast cancer? What if there was an early detection and 100% cure rate for ovarian cancer? What if heart disease and cardiac incidents were more easily recognized in women and more women were saved? And what if there was a much more rapid diagnosis and effective treatment of fibroids and endometriosis, something that impacts myriad women, like so many women, and which can take up to 7 years for a diagnosis. So when you think about the power of research and the power of research investment, and you think about this little girl becoming 20, how can we make sure that we move this forward? And her world looks very different than what our world does today. So the Alberta Women's Health Foundation, again, the work that we're doing locally and as part of the Women's Health Collective Canada, we're a pan-provincial women's health brand, but we are national in scope, creating successful partnerships across the not-for-profit and the private sectors. We connect women's health researchers in Alberta and their work to stakeholder groups nationally. We produce thought leadership papers through public survey and knowledge translation. And of course, as I mentioned, we're a founding partner in Women's Health Collective Canada. This year, we have a lot of targets that we want to reach. We want to continue to offer grant and catalyzed programs to create opportunities for students and young research awards, working with our Women's Health Research Women and Children's Health Research Institute. We want to enable Alberta researchers to join large projects, attract more researchers to Alberta, accelerate awareness and advocacy, and certainly advance clinical care outcomes. And we do that through our support, really through to the Women and Children's Health Research Institute, where we support over 160 researchers right now within that institute. And those researchers are like Dr. Colleen Norris. They're working on, who works a lot on women's heart health, but mature women's health research, prenatal and postnatal health, Indigenous women's health, gynecological cancer research, and research about underserved populations, including rural and remote Albertans. And this is a really important part of our work too, particularly in connection to the Lois Hole Hospital for Women, which is a leader right across Canada, but it is a home and a place of expertise in specialized and subspecialized care for women. So this research impacts care delivery, and sometimes it has immediate and long-lasting impact on women's lives right now. So the implementation of a province-wide fetal heart rate monitoring system, that is something that has been made possible through the work of the Alberta Women's Health Foundation and working with our donors, and certainly the Lois Hole Women's Society was a big part of that as well. Expansion of our women's mental health app. This is the work that we've been doing with Dr. Dawn Kingston, and she is the pan-provincial chair in women's mental health research, which we support. Creation of the Indigenous Cultural Partnership, which I spoke about earlier. This is happening inside our Lois Hole Hospital for Women, which brings together a reconciled model of healthcare for Indigenous women who are in our who are laboring, right? So women in having babies here at the Lois Hole Hospital for Women. The Allard Hereditary Breast and Ovarian Cancer Clinic is another place of research. The Sawin Baldwin Chair, Dr. Cheng Heng Lee holds that, and his research is definitely connected into Calgary and beyond. The research that is involved in determining and measuring the outcomes for women who've had robotic-assisted surgeries for gyne-oncology, so cancer surgeries, is also a big part of research there. So these are things that are directly impacting care. The Alberta Women's Health Foundation, as I said, works in areas of advocacy and also raises awareness. So our first thought leadership paper, called Finding the Fractures, was really about measuring how women were coping during the pandemic and what was happening in their lives. And it really showed us a lot of things, including the number of missed and skipped appointments as a result of issues connected to the pandemic, such as childcare or illness or taking care of elderly family members. So we have our next thought leadership paper coming out soon. It's going to be called Surveying the Silence. And this is a province-wide survey that really asks women a lot of questions about gynecological health and gynecological concerns, and how some of these things have impacted their lives and impacted their careers and even impacted their families. So in terms of how the Alberta Women's Health Foundation has really progressed along the way, you can see there's been a lot of high points here in our very short history. You can see here in March of 2022, or in August of 2022, we announced that Dr. Colleen Norris was named the Cabazan Chair in Mature Women's Health. This was another, I think, real high point for us, because the Cabazan Chair is so important in terms of the chairs that we fund, the research chairs. And I want to share a little bit more about the woman who founded that chair. So Dale Sheard was a member of our board of directors, and she was the chair of our board of directors, in fact, when we launched the Lois Hole Hospital for Women campaign, the Capital campaign, back in 2005. And, it was a very successful campaign that she led and was really instrumental for rallying a lot of other leaders, a lot of them women leaders, who contributed to the Lois Hole Hospital for Women and really led a successful fundraising effort and resulted in the incredible hospital that we have today. And when I think of the Lois Hole Hospital Women's Society today, I think of how the society is really the next generation of that original capital campaign leadership and their vision for what this hospital would be and could be for women and how it would change women's health outcomes. And so you really, their endpoint was our starting point. And because of this hospital, because of the Research Institute, because of the collaboration that's happening with other women's health foundations as well, we have started something now even national. So you can see how all these pieces tie together and will raise the ship of women's health research overall, right? So maybe in 40 years, we're going to be able to say that we've raised billions of dollars for women's health and women's hospitals. And as a result of that, we've eliminated disease, we've improved health outcomes, and things have changed for so many mothers and sisters and daughters. So Dale is credited, of course, as I said, she was instrumental in the establishment of the Lois Hole Hospital for Women in 2010 when that hospital opened. But I also want to share that she started the Cabrazan Chair in mature women's health research. She was very interested in mature women's health. She saw early on as a visionary that mature women's health was really on the sideline. If women's health generally is on the sideline, mature women's health was tucked away in a corner under a blanket. So this is the vision of Dale, to bring that out through the start of the Cabrazan Chair. And so with the support of the Royal Alex Hospital Foundation and working with Dale, that chair was born. And we're all very pleased and proud and certainly grateful to Dale for her philanthropic support of the chair, which continues to this day. All of that to bring me to another introduction of Dr. Colleen Norris, because Dr. Colleen Norris is the latest chair. She, her predecessor was Dr. Sue Ross, who had a tenure as and lead and did amazing work as chair, and did some really incredible work also in rural populations. And now that Dr. Sue Ross has retired, there was a search and selection for the next chair. And Dr. Colleen Norris is an amazing researcher and an amazing collaborator. And we're so pleased and proud that she holds this position now. And I know that she's someone who speaks all across Canada and beyond. And so we're proud to have her here tonight. So with that, I thank you all for listening to my part of the presentation. I hope that I've really kind of shared a little bit about the environment of women's health from the fundraising side and the work that's ahead. It's a heavy lift, but all of us together, Women's Health Collective Canada, Alberta Women's Health Foundation, and our Royal Alex Foundation, and of course, the Lois Hole Hospital Women's Society, that lift is going to be made a lot easier. So thank you, and over to you, Dr. Norris.
Thank you so much. Just incredible work that's going on. And I'm just so excited to be part of that. So I'm just going to share my screen. And you let me know that you can see the beautiful picture. Yes?
We can still only see you, Dr.
Oh, that's no good. That's always the case. So smaller and try again here. So I'm sharing this. Share.
Just while we're getting that going,
Yeah.
I just wanted to say there is a comment in the question and answer box there, just saying essentially we definitely need more advocacy for women's health. So a lot of support out there, as we know. Yeah.
I'm so sorry about this. We had it all set up and
It's all good.
you're not seeing my screen.
It's good now.
Oh, thank goodness. Okay. Okay. So thank you so much. I'm just going to hear it. Thank you so much again, Sharlene. I'm so excited to be presenting today, and I wanted to start with a land acknowledgement and talk about, in her book, Braiding Sweetgrass, Indigenous Wisdom, Scientific Knowledge, and Teachings of Plants, Dr. Robin Wall Kimmerer reflects on the meaning of land to Indigenous people and rights. In the settler's mind, land was property, real estate, capital, or natural resources. But to our people, it was everything. It was our identity, the connection to our ancestors, the home of our non-human folk, our pharmacy, our library, the source of all that sustained us. Our lands were where our responsibility to the world was enacted. Sacred ground. It belonged to itself. It was a gift, not a commodity, so it could never be bought or sold. These are the meanings people took with them when they were forced from their ancient homelands to a new place. Therefore, I would like to begin by acknowledging the indigenous peoples of all the lands that we are on today. I would like to take a moment to acknowledge the importance of the land that we all call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improve our own understanding of local indigenous people and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nations people that call this land home. I am so incredibly grateful to be able to present today. Some of you may know about the idiom, the canary in the coal mine. It actually refers to the former practice of taking caged canaries into coal mines. Unfortunately, the poor canaries would die if methane gas was present, and thereby alert the miners to danger. So it means something or someone who acts as an indicator, an early warning of possible adverse outcomes, or danger. I suggest that women's heart disease is the canary in the coal mine of women's health, and I'm going to tell you why. Maya Dusenbury, in her book, Doing Harm, The Truth About Bad Medicine and Lazy Science, Leaves Women Dismissed, Misdiagnosed, and Sick, writes that apart from reproductive health, also known as bikini medicine, medicine pays little attention to potential differences between men and women, instead taking a one-size-fits-all approach to clinical research and practice. I propose that women's heart health is a victim of not only the one-size-fits-all approach, but that the women are small men approach. More importantly, I'll give examples of how taking a one-size-fits-all, in our case, a middle-aged white male approach, in heart research, leaves women dismissed, misdiagnosed, and sick. And I hope that you too will take up the challenge to change our paradigm of women's health. As I was preparing for this presentation, I was reminded of a story included in Carolyn Criado Perez's brilliant book, Invisible Woman: Data Biases in a World Designed for Men, about the now fortuitous story of auditions for the New York Philharmonic. The concept of blind auditions was introduced, where auditions were held behind a screen. While talented and qualified women and men were consistently auditioning for the orchestra, the percentage of women in the orchestra hovered around 6%. The results of the blind audition were so significant that the screening process continues today, and women make up about half of the New York Philharmonic. Anthony Tommaso wrote in the New York Times that blind auditions changed the face of the American orchestra. What does this have to do with women's health care? You may ask. I propose it has everything to do with women's health. My researching and Google scholaring through the sex and gender and intersectional literature brought me to an article by Hall et al. In their manuscript, Mosaic, a model of stereotyping through intersectional categories. And they quote, and I quote, that demographic characteristics are a key source of bias in our evaluations. Furthermore, they write that employers, so this is in the management science literature, have started to acknowledge that employees are simultaneously members of different multiple demographic categories. And they give the example of a heterosexual Sikh woman. While one may cringe at using these types of categorical descriptions, the authors report that neither researchers nor practitioners fully understand how additional classifications implicitly or explicitly influence our perceptions. So in plain English, when any of us, employers, employees, or clinicians alike, look at someone sitting in front of them, we're making assumptions about that person by what we see. I started thinking, is this what's going on in women's heart health? Furthermore, is women's health, in fact, an equity, diversity, and inclusion issue? At a recent workshop on women and girls' health, my co-presenter, Dr. Katrina Mullaney, said, and I quote, "Vulnerability happens when forces outside of our control limit our opportunities. It strikes me that our research, health system, and policies are, in fact, limiting the opportunities of women to live healthy lives." So a quick trip down memory lane, at least my academic memory lane. I was introduced to the inequities in women's health, specifically women's heart health, with my doctoral work. My study using the newly mentioned approach registry looked at the health-related quality of life differences after a heart attack between patients treated with surgery or PCI and medical management. Honestly, I know we have to let the data do the talking, but from my own clinical background, it was a no-brainer. Patients who have an intervention with whether open heart surgery or a balloon inflation that flattens the blockages feel better almost right away and are able for the most part to resume their activities. However, in doing the modeling, I discovered that females and males reported significantly different outcomes. This really caught my attention. My next thought was, I'll let the world know about this and we'll improve women's heart health in Canada, if not the world, which is ironic given that we're still here today. Did I mention that heart attack symptoms are not recognized in over 50% of women, and that once every 20 minutes in Canada, a woman dies from heart disease? We had no difficulty whatsoever identifying that over and above the heart attack world, females, so not women, and more on that later, showed differences in presentation, treatment, and most importantly, given the lack of recognition of sex differences in males and females, they presented with worse outcomes, including hospitalization and mortality than their male counterparts. Enter Bill Galley, actually Dr. William Galley, who had been on my doctoral committee, but it was Bill who suggested I apply for postdoctoral fellowship to pursue and understand the sex differences in people with acute coronary syndromes. In fact, during my postdoc, I wrote and was funded for a study to explore what over and above sex was resulting in worse outcomes for females. If I say so myself, I'd become a pretty savvy biostatistician, so I'd modeled and controlled the data to death. We knew there was something elusive over and above biological sex. And I was starting to investigate what I labeled as gender roles and their association with heart events. This was based on my own gender roles and elucidated in the book called The Second Shift, written by Arlie Hochschild, that identified that when you add together the time in childcare and housework on top of paid work, working mothers were putting in over a month of work extra a year than their partners. Enter Dr. Louise Pilote. Louise was creating a multidisciplinary team called Genesis, Gender and Sex Determinants of Cardiovascular Disease, and we worked on an application to look at gender and sex determinants of cardiovascular disease. I was able to present my work to date at the first Genesis meeting in Montreal. Those moments when you're able to work things out loud have been turning points in my research career. We collected extensive evidence on behavioral, environmental, and biological factors, and the results completely refocused my thinking, but I think actually set the stage for what we now call sex and gender science. Genesis Practice was a study that included women and men less than 55 years of age who were admitted to hospital having suffered a heart attack. We collected 26 psychosocial or gendered variables and identified 7 which were associated with sex. Higher scores represented behaviors typically ascribed to women. The gender distributions revealed that half the women had more androgynous or masculine gender scores, and 16% of the men exhibited more feminine gender scores. This graph identifies the male scores in red and the female scores in blue. As you would expect, both males and females reported behaviors along this continuum of gendered variables. However, the results were enlightening. On the left, you will see the percentage of participants who returned with a second heart attack within 1 year, and it was equal when we stratified by sex, so males versus females. However, looking at the bar charts on the right, you'll note that irrespective of whether you were a male or female, people who scored higher on the gender index, so reporting characteristics that are typically ascribed to women, were 4 times more likely to return with a second heart attack within the first year. I might add that one of the variables that contributed the most to the gender index was stress level at home on a scale of 1 to 10, which in these COVID times is likely to have increased exponentially for many. And there's significant evidence that it's increased more for women than men. When we produced the Genesis Praxis results, I had the opportunity to present at international congresses. Everyone asked about the variables that made up the gender index. One of the factors associated with worse outcome was hours of housework a week, that second shift issue. I might note that some of the women reported doing over 25 hours a week of housework, and that's over and above everything else women were doing. This was picked up around the world and not in a good way. These pictures ended up making our work seem less legitimate, and they were so sexist. No matter how much I tried to explain, like the book, The Second Shift, the hours of housework were on top of everything women and men were already doing. Whether you were a man or a woman, it was a reflection of managing a family and a household. And while we'd have to do a lot of work to mechanistically connect housework to the function or malfunction of your heart, for me, it wasn't a stretch to say that the environment, culture, roles, resources, and opportunities for women were being reflected in their heart health. My biggest surprise and disappointment actually was the comments that resulted from our attempts at measuring gender. It's a soft science. What is the mechanistic explanation for this? You can't put something like gender in an index. Conceptually, it's not binary. What are characteristically typically ascribed to females? And isn't that sexist? And how is this clinically relevant or even practical? In fact, from a knowledge translation perspective, all of our information backfired. It was encouraging then that while I noted a significant inertia in moving sex and gender measurement forward, this was not the case at the CIHR, the Institute of Gender and Health, and the Canadian Cardiovascular Society. They were getting together a guidelines committee for the management of heart attacks, or ST elevation MRIs, a specific type of heart attack. And I was asked to be the sex and gender champion on the committee to look at how many females were included in the studies that were used for creating clinical practice guidelines. So for those of you here tonight who are unfamiliar with this process, specialist societies in Canada, like the Canadian Hypertension Society or the Canadian Society of Nephrologists, so kidney specialists, get together. They write up, review, and update clinical practice guidelines. They review all the research and develop guidelines for the best treatments for care. The guidelines are based on any study done worldwide that's high quality randomized clinical trials. This was a pilot project of the Canadian Cardiovascular Society. And I have to comment that there was one other woman on the guidelines committee of 20 people. And even after having a 1-hour meeting with the chair to explain what I was doing, I was introduced as, quote, Colleen, everyone else who's doctor, is a nurse who's doing some work in women's hearts. I'm a big fan of Ruth Bader Ginsburg and always appreciated her quote, reacting in anger or annoyance will not advance one's ability to persuade. So I persevered. The results were actually shocking to me. The 21 PICO questions, or the way researchers put limits on what studies will be included, yielded a total of 180 studies, 175 of which were included in the clinical practice guidelines. The mean percentage of women in these trials used for the guidelines was 24%. The participation to prevalence ratio is a metric we use to identify the representation of a specific population. The important point to note is that a PPR of less than 0.80 indicates that a population is underrepresented. The mean participation to prevalence ratio was 0.62, meaning females were underrepresented in the research used to decide how best to take care of men and women having a heart attack. Please note that one of the trials used for the evidence in the clinical practice guidelines had no females in the trial. Not surprisingly, our conclusions identified that no studies included gender as a variable, and that only one study out of 175 provided sufficient evidence to confirm that the guideline recommendations for the management of a heart attack, or STEMI, could be applied to females as well as male patients. After much discussion, which I still regret not being stronger at, the following statement was included in our guidelines. While we make the agnostic assumption that recommendations in this guide hold equally for men and women, we acknowledge that the published literature are inadequate to confirm this clearly. The barriers to incorporating sex and gender in the development of clinical practice guidelines included inadequate enrollment of women in randomized clinical trials, lack of publication of the outcomes stratified by sex, and lack of inclusion of gender. I have to interject here that a few weeks ago at a PhD candidacy exam of one of my students who was doing a feasibility study of a cardiac rehab program for women with a thing called SCAD, which is spontaneous coronary artery dissection, which the Heart and Stroke Foundation reports 90% of SCAD cases are women, mostly between 30 and 60 years of age, and it accounts for 25% of all heart attacks in women under 60 years of age. One of the examiners suggested that would it be unethical not to include men in the study. To be perfectly honest, my thoughts were actually, we have been doing men's heart research for 100 years, and it may be time to say, given that we know about women's heart health, that it's unethical to women to include men and muddy the water of the presentation, diagnosis, and treatment of outcomes for care of women with heart disease. By basing guidelines on outcomes of studies for which males are the majority of participants, the clinical and physiological variation that exists between sexes is often neglected. The prognosis for females may not be favorable as their male counterparts, as the treatment regime might not have been ideally related. More importantly, until we have enough women enrolled in clinical trials with sufficient sample sizes, sex disaggregated data not might, but would provide indication of guidelines for treatment regimes. To address the gap in care, it's imperative to acknowledge the existence of these disparities in treatment and management plans. And here I thought collecting sex was simple, and it was gender that was going to be the issue. So now finally you say, maybe she's going to tell us, how will research and measurement of sex and gender improve women's health? Well, I believe our work in sex and gender science will set the stage for exactly that. The next question then is, how do we actually measure sex and gender? This quandary has been reflected in comments like, I know I have to do it for research, but how actually does this relate to clinical practice? I had a conversation with a CV clinician scientist who said, and I quote, honestly, how does the fact that someone identifies as gender fluid affect how I will treat them for an MI or myocardial infarction? There's lots to unpack there. However, we have identified that females are underrepresented in cardiovascular trials, which means that clinical trials, the basis for care, lack evidence on the outcomes of treatments and procedures for females, which falls under the sex differences umbrella. My second point is that gender identity, while an important aspect of gender analysis, is not the only aspect, but more on that later. As Sharlene mentioned, and we're going to talk about it here, in exploring the biological contributions to human health, to sex matters, Wiseman and Pardue, who led the committee on understanding the biology of sex and gender, defined sex as a classification of living things generally thought of male or female, according to their reproductive organs and functions assigned by chromosomal complement, and gender as a person's self-representation as male or female, or how that person is responded to by our social institutions on the basis of their individual's gender presentation, so how we look to others. Importantly, they note that gender is shaped by environment and experience. What does it actually mean that every cell is sexed? This might be a review, but it bears repeating. Your body is made up of trillions of cells. Each contains DNA. DNA is made up of thousands of genes and is wrapped tightly into structures we call chromosomes. Each human cell has 46 chromosomes, or 23 pairs, since chromosomes come in pairs, with one from your mom and the other from your dad. The 23 pairs of chromosomes are called sex chromosomes. And those chromosomes are either called X or Y. Males have one X sex chromosome and one Y, and females have two X chromosomes. More importantly, and actually reinforced by evidence throughout COVID, the genes on the X chromosome are important for how the body grows and functions. The fact is that females have two X chromosomes in every cell in their body. And as girls are growing up, they have a special mechanism that randomly turns off one of the X chromosomes. So when one turns off, the other's still working and its genes are expressed, which means the traits show up in those females' bodies. This process of turning one X chromosome off is called inactivation. Since not every cell turns off the same X chromosomes, the cells can express those genes differently from each other. And this is called cellular mosaicism, which not only means that females are more diverse than males, but also that there's an incredible diversity amongst females. So I ask, how is it that comparison group for females, if there's enough females to compare in research, is still males? To be frank, all women's health research outside of bikini medicine, so that's medicine that's based on the female body parts that can be covered by a bikini. So research in women's heart health requires that the sample cohort has male comparison groups. And even as recently as 2022, we were told in a manuscript focused on premature heart events in women would only be published if we provided a table that included the demographic and clinical comorbid events of the men in the original cohort. So I put it to you that comparisons imply that there's a gold standard. And every time we do studies of diagnosis, treatment, or outcomes of care for any health issue and stratify by sex, males and females, we're reinforcing the idea that the male model is the gold standard. And in fact, today, in 2023, in the heart world, I would venture to say that also in the brain, kidney, liver, lung, we don't have evidence on the diagnostic methods, the treatment, or the care and outcomes are right or effective for females. Concurrently, it also behooves us to reflect on the elephant in the research room, which is a total lack of research being done or funded in different top areas related to women's health. In an op-ed published in Women's Day last year, Sharlene Rutherford spoke and wrote, and I quote, "Women's health research receives no more than 8% of medical research funding in Canada. While we founded the Alberta Women's Health Foundation, knowing this, we have since made a dramatic discovery. Here in Alberta, only 3.4% of funding goes to women's health. Now, some may argue that women or females are included in basically all funded research done in Canada, but there's two issues here. The first is that the percentage of women is not sufficient to draw any conclusions or recommendations. But more importantly, given the slide earlier regarding sex and X chromosomes, we're barely scraping the surface regarding our understanding of women's health. Taking a page again from Ruth Bader Ginsburg, when asked, when will there be enough women on the Supreme Court? And she said, when there are 9. And people were shocked, but no one ever raised the question of having 9 men on the Supreme Court. I put it to you that no one has ever raised the question about just doing men's heart health research. Given the gaps in care, it's now time to do exclusively female or women's health research. So back to sex and gender. Sex is defined as biological constructs, often understood or misunderstood as binary and female and male. It encompasses hormones, genes, anatomy, and physiology. And as Sharlene said, it affects the propensity for prevalence and treatment of health conditions. There are big differences in drug absorption, body composition, metabolism, diseases, and conditions according to your sex. Gender is a social construct. It's developed by social sciences, referenced, described, and based on gender identity, including women and men. There are many other terms to reference gender identity, like gender fluid and cisgender or gender queer, but this is not the only component that makes up the construct of gender. It's much more. It's linked to power and economics and social status, and it's distinct from sex. It has 4 dimensions of which have been identified in order to begin and explore the association of gender on health. We've talked about gender identity. The other 3 are gender roles, gender relations, and institutionalized gender. So how do we measure sex and gender in research and ultimately clinical practice guidelines? Enter Dr. Louise Pilote, who was once again ahead of her time. She conceived of a Going Forward consortium, and along with Dr. Valeria Raffarelli, we applied for and were successful at getting an internationally funded grant on GenderNet Plus and through the Canadian CIHR. At our first meeting in Montreal, we created what we called our wish list of gendered variables, and we used the framework to identified by Johnson and Greaves to categorize the variables into the 4 dimensions of gender identified in Women's Health Research Network PRIMA that include gender identity, gender role, gender relation, and institutionalized gender. This table was developed to further identify gendered factors that are now known to affect health, health access, health treatment, and health outcomes. So we know sex and gender influence our risk of developing certain diseases, how well we respond to medical treatments, and how often we seek care. And while it's important to clearly distinguish between sex and gender, we also need to understand the dynamic relationship between these and other factors that influence health and well-being. Intersectional factors like indigeneity, income, social status, support, education, employment, ethnicity, geographical location, they all contribute to the varied experiencing outcome for men, women, girls, and boys, and gender diverse people. We fully recognize that it's important to examine women's health in the context of a multitude of factors that influence health. The concern is that many analyses of health data are now stratified by sex and gender, making it difficult to understand the relevance of research findings to the health of women. There are significant gaps in our understanding of diseases and conditions in women that result from continued over-reliance on male models and the historical over-reliance on men as participants in clinical trials. Interdisciplinary approaches, refined measurement tools, and integrative approaches are critical to addressing the health challenges of women today. So I strongly suggest it's time for significant paradigm shift in women's health. No more comparisons to men, but rather we focus on using multidimensional framework developed by the Institute of Gender and Health in the US to improve the quality of women's lives, reduce their disease burden across the life course, and address health disparities for populations of women greatest risk for disease. Women's health research is the study of health across a woman's lifespan in order to preserve wellness and prevent and diagnose and treat disease. Now I'd like to present the evidence that we have on the association between sex and gender-related factors based on where women are at in their life cycle. You'll notice that I also talk about the association between life cycle position. So by life cycle, I mean puberty, menstruation, childbearing age, pregnancy, perimenopause or menopause or postmenopause, and why I believe heart disease is really the canary in the mine field of women's health. Research has identified there is an association between menarche, menstruation, contraception, and heart events. Early or late menstruation, menstrual cycles that vary, or contraceptive use formulas and interactions with other risk factors like smoking and hypertension and high blood pressure have been associated with women's heart disease. Research has demonstrated that infertility is linked to a higher risk of future heart disease, compounding the fact that there's little to no evidence on the hormones used in infertility treatments and outcomes on women's health. PCOS, or polycystic ovarian syndrome, affects women of reproductive age, and it results in increased risks of obesity, insulin resistance, and diabetes, and other metabolic risk factors. The PCOS risk factors, like being overweight or having insulin resistance diabetes or high blood pressure, are associated with cardiovascular disease. Overall, women with PCOS were 19% higher risk of developing cardiovascular disease. Endometriosis is associated with systemic chronic inflammation, similar to other diseases, and heightened oxidative stress, and increases a woman's risk, again, of coronary heart disease, as well as kidney disease and others. In their large prospective cohort study, UNO concluded that laparoscopically confirmed endometriosis was associated with high risk of cardiovascular disease. The association was strongest in young women. Hysterectomies or oophorectomies, or so the removal of the uterus or ovaries, was also associated with the higher risk of coronary heart disease, which could partially explain the association between endometriosis and further disease. Pregnancy has been called the first stress test a woman undergoes. Pregnancy poses a physiological stress on all of our system, and it undergoes structural and hemodynamic changes to accommodate this increased blood volume. Reproductive history, because the association has been identified between complications of pregnancy and heart outcomes, the move is now on to include your reproductive history. Questions it should include: how many pregnancies did you have? Did you have complications like high blood pressure? How much did your baby weigh? Were the babies born prematurely? This should be asked as part of any woman's full complement of a health assessment. Estrogen's known effects on the cardiovascular system include a mix of positive and negative. Over the years, evidence was accumulated that suggested estrogen also helped protect women against heart disease. The accepted thinking was that the drop in estrogen levels associated with menopause accounted for this jump in heart disease. And when estrogen levels declined, levels of cholesterols increased and the good cholesterol decreased, and it led to a buildup of fat cholesterol in the arteries that contributed to heart attacks. It made sense that replacing estrogen through hormone replacement therapy would potentially improve heart health. This thinking actually contributed to a huge rise in the number of women who were prescribed estrogen. Then in 2002, the Women's Health Initiative began the widespread misinformed practice that hormone replacement therapy increased the risk of heart disease and breast cancer. The conclusions to date are that endogenous estrogen, so the one that's created in your body, is cardioprotective. However, the effects of exogenous, created in the lab estrogens and progesterones, are complex and less clear. Premature menopause has been associated with increased risk of cardiovascular disease, and the time and the type of menopause must be considered whenever you're assessing cardiovascular risk. 80% of women with people with osteoporosis are women, and they experience rapid bone loss at menopause due to these hormonal changes. As an aside, I'm on my own crusade to change the language around menopause. We don't say the symptoms of puberty or pregnancy. Menopause is a natural process. We know what happens to our vasculature when estrogen is no longer produced. There are now cohort studies that have demonstrated that using the new biosynthetic hormones that completely replicate our own estrogen do a better job of preventing cardiovascular events and mortality compared to the drug statins. I'm going to repeat that. Biosynthetic hormones, when started during perimenopause or menopause, do a better job of preventing heart events and death in women than statins when they are started early enough. Depression is more prevalent in women than men, both before and after a cardiac diagnosis. Younger women diagnosed with heart disease are less than 60 are 3 times more likely to become depressed than the male patients. But depression is often considered a normal reaction after a heart attack, and it should not be. Autoimmune diseases are more prevalent in women. Among individuals, autoimmune disease, the highest cardiovascular risk was seen in systemic sclerosis, Addison's disease, and lupus. Cardiac symptoms can be misinterpreted as being related to autoimmune disease or even clinically silent. Therefore, a careful cardiac and autoimmune disease assessment has to pay attention to these risk factors. Sex and gender-related differences in kidney disease, presentation, diagnosis, and treatment are impacted and will impact the cardiovascular disease risk in women. Studies have reported that kidney disease is an independent risk factor for cardiovascular disease. Cardiovascular diseases are the leading cause of death, cardiovascular diseases, in women with breast cancer over 50 years of age. The increase in heart events among breast cancer survivors is due to the cardiotoxic effects of some of the breast cancer treatments and overlapping risk factors for breast cancer. including age, physical inactivity, obesity, insulin resistance. There's a well-established link between anthracycline chemotherapy and congestive heart failure. Cardiovascular screening in women must include breast cancer history and vice versa. In summary, there are factors associated with every stage of life, starting at puberty right to the end of life, including work on hypertension in women that's associated with dementia. Did you know that 2/3 of women with people with Alzheimer's disease are women? That brings me to my current focus. You may notice my passion for women's health in general. I was fortunate last summer to be awarded the Caverson Chair in Mature Women's Health through the Faculty of Medicine, WICRI, and Alberta Women's Health Foundation. Our current research focus includes identifying the associations of sex and gendered factors in the diagnosis and treatment and outcomes of health issues. We're using a cohort of Alberta women to pilot an evidence-based sex and gender specific detailed history and screening for women's heart health using a life course framework. In Alberta, 300 women a year go to an emergency department with chest pain, discomfort, heart-related issues, and were discharged home and returned within 30 days, having suffered a myocardial infarction or a heart attack. And these numbers don't include the women who died prior to coming back to the hospital. Is there something about this cohort that may help us identify red flags that we can report to the people taking care of these women? But I also started thinking about the clinicians taking care of the women. How do we understand what their experience of encountering a woman in the ER visit? Is there an intersectional bias happening? Back to the New York Philharmonic example, what are we seeing, implicitly thinking as clinicians as we meet women in the healthcare system? Is this a comparison issue? Men clutch their chest and have elevated troponins. Are we deciding that a woman is in a certain life stage, say perimenopause, therefore it's likely that these are symptoms of perimenopause, which are in fact eerily similar to heart symptoms in women? This is a woman, say age 46. I'm thinking likely perimenopausal. These symptoms this woman is describing is likely related to perimenopause, and it's compounded by other pre-health intersectional stereotypes like age and indigeneity and an obesity bias that's been recognized. In Alberta, 300 women a year, we are planning to expand the sex and gender survey to women's health at the Lowesville Hospital for Women. I've spoken today about the association of being female and or a woman and heart health. While they've long stopped asking, the only question that I've been ever asked when going to a doctor in the old days was, when was your last menstrual period? My belief is that we are absolutely in the dark about the associations between the life cycles and health and disease in women. Because of estrogen's significant effect on the vascular system and the Red Dress campaign in the US and Wear Red in Canada, we started to address these significant factors in women's heart health. However, it's not a stretch to suggest that it's the same situation in women's kidneys, livers, brain, in fact, women's health in general. Female and women are not small men. There are differences right down to the cellular level that have not yet been explored. Also, on the advocacy front, I would be remiss if I didn't take this opportunity to mention Wear Red Canada Day. It's celebrated annually across Canada on February 13th to raise awareness about women's heart health. Events are held across the country to serve as a reminder for all Canadians, but especially Canadian women, to be mindful, curious, and protective in the management of their heart health and heart health in general. As chair of the Prairie Committee for the last 2 years, we continue to share our key messages, the most important of which applies to all women's health. Put your oxygen on mask first before assisting another. The only way to advocate for yourself is to understand and take care of your own health. In conjunction with the CK Huey, this year, we're planning a women's heart health photo booth situated in the Lowesville Hospital for Women that will not only take a picture of anyone, especially those wearing red, but we'll have information, brochures, key messages, and pins about women's heart health. Anyone and everyone is welcome to stop by. I would like to thank you for your attention and indulging me over this time reflecting on women's health and the opportunity to truly move the dial on women's health. research. The importance of this work at this time in our history cannot be overstated. Thank you to Dale Sheard and the Caverzon Chair, WICRI, the Alberta Women's Health Foundation, and the Royal Alp Hospital Foundation, who have provided support and who consistently include me in all things women's health through panels, presentations, grand rounds, even Facebook webinars and Twitter chats. I really look forward to any questions that you may have. Thank you so much.
Thank you so much for your informative presentation, Dr. Norris, and thank you, Sharlene. I will be facilitating a question and answer period just briefly. And it looks like we did have a couple questions come in. One, I think the first one is more for Sharlene, when you mentioned about the survey for women, gynecological health in Alberta. Can you mention how people can access that?
Yeah, absolutely. Thank you, Brianna. So the survey results are going to be released early February, and we're going to release them over social media. We're going to release them through our website, so they'll be accessible. And it's going to be a release over a number of weeks. So what the survey revealed is really 5 key themes when it came to gynecological health and women's thoughts on how they're impacted by healthcare. And so we're going to be releasing these across those weeks, leading up into the beginning of March. Which is of course International Women's Day, March 8th. And week. So yeah, starting in February, all of this will be released for sure. It's called Surveying the Silence.
Excellent. So surveying silence, the data has been collected, so it's not something that we're looking for participants for at this time. Excellent. No. Well, I'm excited to see the information as it comes out. Thank you. The next question is a little bit of a question combined with a statement, we're acknowledging the need for more women's health research, and they also want to ask what else can be done to affect policy changes within government or provide more funding with respect to multidisciplinary clinics that focus in women's health. It is the point here that this individual is making is also that it is very hard to get healthcare for women when many can't access a doctor or somebody that has the knowledge. And I think that also speaks to some of the standard of care guidelines that Dr. Norris was mentioning, how many of our clinical standards of care are non-gender specific. So this is I guess a question for both of you, or a statement maybe both of you can address.
I think I was on a tremendous seminar, webinar this morning through Women's Health in Canada that was put on, and they were speaking to it from British Columbia's perspective of changing policy. And the bottom line is we need the data to say that we don't have the data, and that we need to be collecting it. And I was really thinking about this because it's really tough to get Tri-Council funding at this stage, whether CIHR or heart and stroke, if I don't have a male cohort. And that's why someone has put in, what's the Caverzon Chair? Well, the Caverzon Chair is a chair that allows me to do mature women's health research and to start collecting that data to be able to say just on women, that I now have the ability to say it's a chair in women's health research. So I'm collecting data on women. It's not going to be on men, and start being able to get the numbers together to change policy, to say, that women are not accessing care. In the UK, hormone replacement therapy is free in Scotland and Wales for women, and England is pushing to get it. And England is pushing to get actually menopause days like pregnancy, maternity relief days, because they quote that it's hemorrhaging women who have so much experience and practice in the workforce that have to take away because they aren't being cared for through the perimenopause and menopause, when we know what works, but no one's being able to access that care.
Yeah, and I think I would add to that by saying one of the things that our earlier report, Finding the Fractures, listed was really a list of very practical sets of guidances that we could all pay attention to. So everything from the division of labor outside of your workplace, so in your home, making sure that that is happening, right? Making sure in the workplace that there are opportunities, good policies on mental health and sick time, and being able to take days where you can do a health check. Things that are happening in other countries, you know, proactive health days that everyone can take. It's not just for women, but these are things that, you know, are really, you know, practical pieces of advice. You know, how do you relate to your coworkers? How do you speak with your coworkers? Is there opportunity to have these conversations? Even for some of the larger companies and even corporations in Canada, they're starting to see the value of having, you know, lunch and learns around health and how to take care of your health, and to bring in researchers, you know, like Dr. Sandy Davidge or like Dr. Colleen Norris, to talk about things like heart health, or the, you know, how does the symptoms of a heart attack differ perhaps for a woman? Like what should you look for? Why is it not okay to just say, you know what, I'll go later because I still have to take care of dinner, or I've got company coming, so I'll wait and go to the hospital later. Things like that. So that was Finding the Fractures. In terms of advocacy, you know, there's nothing like making sure, you know, you can, it's a common thing to write to your MLA, but to say to your MLA, look, women's health needs attention. When we're talking about healthcare and healthcare reforms in Alberta, what's the conversation like around women's health? Where's the roundtables on women's health? What are we doing here? And that's, you know, that's some of the work we're doing with the Alberta Women's Health Foundation, is we're trying to push that forward. We want that conversation happening because we know there needs to be more multidisciplinary clinics. We know there needs to be more funding. You know, the truth of the matter is that health foundations like ours, we are the innovation budget for our health system. That's not really widely understood, but it truly is. We bring the innovation into the health system through community support, through donor dollars, through grant dollars that we achieve. So we have an important role to play, but we're also great connectors in the community and can bring people together to have these conversations. And you know, certainly, you know, a talk like this helps to raise everyone's information and to ensure, you know, empower people to take more action.
Absolutely. And so I think in summary, we're looking at gathering data and then education as far as both patient and physician education, and then also advocacy. As an individual level, we can write to our MLAs, we can engage and support groups like this one, and continue to build and advocate and just demand women's healthcare in Alberta and beyond. So thank you both. I think a few more of the questions here pertain to hormone therapy, menopause hormone therapy. And so maybe just in the interest of time, to be respectful of everyone's time, we'll kind of lump these together a little bit. So basically what the questions are around is about, is there efficacy of menopause hormone therapy for women beyond 5 years into menopause to help manage symptoms, so brain fog, emotional dysregulation, anxiety, depression, and then moving into what is the current thinking of hormone therapy for cardiac health. So I think they're kind of two different questions in the sense that we're looking at like symptom management and then also prevention. Dr. Norris, I'm not sure if you want to tackle that one.
So I'm really starting to investigate this to try and figure out what's going on, because you still will have cardiologists and primary care people tell women who've had a heart event that you can't be on hormone replacement therapy, and that's just not the case. It's each individual woman has to be looked at as to what will work and what are the risks and benefits. The one thing about the timing hypotheses that 2002 I was mentioning is that everyone, there were women that were 10 and 12 years out from menopause that were put on estrogen. And that's why that study, we shouldn't be looking at those results to say that there's no hormone therapy for women because of those risks. And I think what we really need to push as we're moving forward in this through perimenopause and menopause is we need lots more evidence, but we need to understand that every woman is unique. And if someone is telling you that you can't have hormone therapy because of the studies, then you've got to say, well, you've got to find someone else, that's going to have that discussion with you and say, in your unique condition, what you're bringing to the table, this is what would work and what wouldn't work. 5 years out, I think the evidence would say you're still fine. It's, the women were 10 and 12 years out from having hit menopause, which is a full year after your last period. So I honestly think when you talk about the little girl at the beginning, I think we're going to be, the biosynthetics are getting so specific to each woman. I think that we're going to be taking them like vitamin B and those sort of things as we hit perimenopause. Just because we weren't meant to live as old as we live, we weren't meant to live 40 years after we hit menopause. That wasn't evolutionary, the way evolution was planned. So we got to adapt to the way our bodies are now.
100%. I'm so passionate about advocating for hormone therapy when appropriate. And I think it's really important that everybody has that individualized care and individualized conversation, because we don't have necessarily, it's very difficult to make blanket recommendations, especially with a cardiac population or even in the context of bone mineral density. So it needs to be a one-on-one conversation. And if somebody's primary care provider doesn't feel comfortable having that conversation, we need to have resources for those individuals, I think, to access. So yeah, exciting times. Hopefully. Another thing in here that was brought up by Barbara was just, can we be provided a cheat sheet of information to give us some information when speaking with our MLAs? I feel like that's something that we can probably take on with the Women's Society, or at least I'm happy to volunteer myself for that. So we can definitely work on getting some information together, and we can rely on our researchers as well to help us with creating some of that information to send out. So I think just in the interest of time, we'll probably begin our closing there. I'm just going to hopefully not too clumsily share my screen. Okay. That should be all right. And just thank you so much for all this information this evening, Dr. Norris and Sharlene. I love these talks, and I love learning. So thank you so much. And I think that, I want to thank the community for being here and continuing to make this online event successful. If you would like to continue to support the Women's Society, we would love for you to consider becoming an active monthly donor. Now is a great time because if anyone signs up today to become a supporter, and now the value and what we can do with resources as we gain more supporters, you can scan the QR code here, and you will be entered to win a draw for this exclusive Hope Box. You can also go directly to the website, the LHHwomensociety.com, where you can sign up or learn more about what we're doing. Thank you so much to those of you who have already donated during your registrations, and to individuals and businesses who support monthly. We appreciate you so much. So thank you. Last but not least, thank you to Alberta Blue Cross for sponsoring our What the Health Talks. And don't forget, a feedback survey will go out. If you fill it in, you'll be entered to win a $25 gift card courtesy of our friends at Alberta Blue Cross. And you'll be contacted via email if you are the winner. Now, again, on the topic of heart health, that's what we're sticking with for February. So in addition to February 13th being Wear Red Day, we will be hosting our next What the Health on February 23rd. So please join us. And thank you again so much, Dr. Norris. I always learn so much every time I get to hear you speak. And thank you, Sharlene, for your information as well. I feel very fired up to continue to advocate for women's health. So thanks everyone for being here today.
Thank you.